Good afternoon, everybody, and welcome to this session. I'm sure everybody must be thinking, oh, another myopia session, because, of late, I think this has been the most, go-to factor as far as the CEs are concerned. So this is a little bit different, I can say, because it's a panel discussion. And at the end of the panel discussion, there is an important announcement as well. So without any further delay, let me introduce the panel. I'll go in the order of how they are sitting on my screen. To start with, Anuradha. Dr. Anuradha is the principal of Elite School of Optometry. She's also part of the Myopia Task Force of OCI. And she does a lot of work in terms of school eye screening. So myopia is something that I think she eats and drinks in terms of, school screening and refractive error. Below Anuradha is Dr. Pavan. Dr. Pavan is heading the myopia research at LV Prasad Eye Institute. He's also part of the OCI Myopia Task Force. Good afternoon, Pavan. Then is Anita, who is going to moderate the session, and she's head of operations of OCI. So I'll be handing it over to Anita pretty soon. Anant Lakshmi has just joined us as a representative from Essilor, and she's the professional head there. We also have Professor Monica Chowdhury. She is a very well-known educator as far as North India and other parts of India are concerned, a long tenure at AIMS, and then after that in various educational institutions. And she's currently freelancing and consulting with various practices at present. Dr. Reggie is an ophthalmologist, a very good friend of ours as well. Dr. Reggie Thomas is a consultant at St. John's Hospital, Bangalore, and he also has his own private practice. He has a very keen interest when it comes to refractive errors and contact lenses, unlike many of the ophthalmologists. So his interest areas are slightly different, I would say. And we have Radhika. Radhika, you're there?
She's there. Yeah, she's put on a, she's actually there.
Yeah, so Radhika is, I think she's trying to put on a video. She's traveling as well. Radhika is the business head of Essilor, and she's also involved in the myopia product, which Essilor has been launching, if anybody's familiar with that, in the past few months. So Radhika is handling all of that. So welcome everybody, and over to you, Anita.
Thank you, Lakshmi, and welcome once again to our esteemed panelists for today's session. And as you all know, the topic of today's panel discussion is again a very hot topic, and rather a topic which has garnered worldwide attention. So without much ado, let me get started with the opening remarks from each of our esteemed panelists. So before I put forth any question, I would request Dr. Anuradha to set the tone for this panel discussion and let us know, has the myopia pandemic really hit India? Is it really a public health concern as far as India is concerned? Because it's spoken across the globe, and the incidence and the prevalence rate of myopia is really great. And has it really reached India, or is it still in the nascent stages? Is it a public health concern? So Dr. Anuradha will begin with her opening remarks, and this will be followed by Dr. Pavan and the rest of the panelists. Over to you, Dr. Anuradha.
Thank you, Anita. Thank you, OCA, for yet another good round of panel discussion. Though, Lakshmi, you said that again and again we are listening to myopia. Still, I feel there is a lot to learn. There is a lot to be conveyed to every stakeholder of myopia. So, Anita, like you asked me, what is the current state? Is it really a pandemic? Few years ago, I used to have the standard statement. I can share my screen on this. I used to say, whenever somebody asked me about the prevalence of myopia, then this is what I used to tell people. Okay, the prevalence is like this. It varies. It has a gradient in different children that is present in the tribal areas, villages, or government schools, the private schools. So if you see the prevalence of myopia, these are the pre-COVID status. If you can see in the tribal areas, the prevalence of myopia from our studies was less than 0.5%. It was just 0.22%. And in the villages, it was anywhere around 1.5 to 2%, myopia being 1.12. And the government public schools, the number was somewhere around 3.57 to 4% in the public schools. And in the private schools, if you see, it was anywhere between 17 to 18%. But and then, and there is also Pawan's paper on the temporal trends of myopia with the urban children, among the urban children. And he showed that by 2050, almost 48% of these urban school children would be myopic. So there is also evidence on the trends of how myopia was going to be. Then, as you said, came COVID, and then we were all already, this was itself a huge burden. And then with COVID, we were all wondering when there were a lot of reports about how it has changed globally. And we saw that after COVID, post-COVID, this was our results. Among the government public schools, this was done in 2021, late 2021. If you see here, you can see even among the government public schools that are present, the prevalence was found to be somewhere between 21% of refractive error, and myopia is 19.53. So this is a huge jump. We are yet to know the status among the other areas. We are working on it, on the tribal areas and the villages and in the private schools as the trend changed. But if you see, this is the current scenario that we are seeing. Even among those schools that are present in the rural areas, we see close to 10%, though we are yet to publish that. But anywhere above 10% is the current scenario that we are facing, actually. Yes, Anita, I am done.
Dr. Pawan, over to you.
Thanks for the nice summary, Anuradha. I think you have captured pre-COVID to post-COVID. Talking about is this really a noise? Maybe it is a noise. I think it's much needed noise as of now. I'm saying that this is much needed because we are still looking at the prevalence rates close to 25, 30. And if you compare it to the East Asian countries, they're already blown up by 80 to 90% in teenagers. So that's number one. Talking about the other aspect, which is very important, is the progression. Yes, it is noise, and it is very important because, you know, once a myope, you are a lifetime myope. Today it's -2, you're not staying with -2, but in certain people, it jumps to -3s and 4s, and then, you know, there's no stopping there. I want to highlight one of our papers from 2020, where we looked at the myopia progression and in children and young adults. We found that Indian children progress by about half a diopter on an average. If you take about 7,000 individuals in that data, on an average, we found about half a diopter jump every year. What is important or what is striking is about 15% of them progress by good 1 diopter. These are the ones who are, you know, likely to go to high myopia or maybe have more serious complications. Thanks to COVID, we are not now seeing half a diopter anymore. I think whoever is coming to the clinics, we're seeing huge jumps. And this is no exaggeration. We're talking about half a diopter 2 years ago, but now I think it's obviously, you know, very evident to see 1 diopter, 1.5 diopter jump in 1 year. So long story short, I think there is clear evidence of myopia progression, and it is definitely time to act. And that noise, whoever calls it as noise, I think it's much important. Anita, over to you.
Professor Monica?
I think awareness for the last 1 year, we've been talking, hearing, and it's speaking up. There are a lot more discussions. Most of the professional meetings, the topics covered are myopia control. The individual is also trying to find out what's coming up in it. There is a lot of industry interaction with the professionals, And it's a haphazard kind of awareness, I would say. There are doctors, ophthalmologists, optometrists who are learning one by one. Yes, this new thing has come up. This is an optical correction. This is a contact lens option. This is a kind of pharmacological option. But when the patient is right in front of them, they do not understand what is the process to handle it. Is it just on the basis of, most of the time it is realized the ophthalmologist would not know the other options of optical corrections or the other, so they will limit themselves to a pharmacological decision. And the other one who is more into the opticianry would talk only about optical. The third option is not there, but the eye and the patient and that child has to be looked into totality. Whatever options are available, the awareness has to be clinically based. There has to be baseline findings, especially of the axial length, which I don't think everybody is aware of. If we are processing a myopia control, we need to know. And what is the follow-up status? In totality, I would sum up to say awareness is picking up, a lot more has to be done. And what has to be added is more professionally and clinically strong people have to come forward.
Thanks, Professor Monica. Dr. Reggie, your take on the myopia pandemic, please. Dr. Reggie, you need to unmute, please.
Okay, sorry. Many of us are definitely aware that the incidence of myopia is increasing. The public may not be aware about this, but there is no doubt, because we've already know from research and data that there are certain etiological factors, and those factors have definitely only increased, and the exposure of children at a lower age or in the ages from 4 to 10 is much more. Like, one, the number of myopes being more, obviously hereditary factors become more. People are more, they never had, we had textbooks, we had notebooks, now it's all laptop based, well, now it's mobile based, and therefore the quantum of the eye being used for near work is much more. And this being so, and competition being so much more, children are more indoors than outdoors. And we, again, there's data which definitely says exposure to light, exposure to being outside definitely holds on to, prevents the progression of myopia or even the incidence of myopia. Now, when we're in a world where this is definitely much more, so we definitely know that the incidence of myopia is definitely more, not just the incidence of myopia, incidence of high myopia is even worse. So, and there is substantial evidence to show that this is more than doubled or tripled and will continue. That process will continue. When we know this process is going to continue, we need to know what strategies or what we can do to decrease this. If we can't take off the number, at least the progression. And for that, I think we as ophthalmologists, optometrists, opticians, we need to know what are the possible available mechanisms or the treatments which are available to at least decrease the progression. The numbers is a big question whether we can really decrease, but at least the progression definitely we can. And of course, we have quite a few avenues to that.
Thanks, Dr. Reggie. Over to you, Radhika.
So thanks, sorry for the technical issue earlier. So I think for us, especially as a manufacturing company, I remember up till almost 3 years, 4 years back, we always said myopia was a Southeast Asia problem. It was a China problem. It was a Japan problem. It was not necessarily an India problem. And I think much to our horror, and I think that's thanks to the Shankar Netalia STEM study, we actually are seeing 1 in 4 children actually having myopia, which is 25%. Now, I've been spending the last almost 1.5 years traveling, meeting up with ophthalmologists, with optometrists, with ECPs, with parents, with children groups. I think myopia is known in pockets. So I think OCI, you're very active as far as myopia is concerned. You have some ophthalmologists who have started the conversation with parents. You have a lot of ECPs that have really not had this conversation big time with their patients. You have parents who have myopia. Yes, they are aware that anything high in their children could lead to issues later on in life. But I would say largely the public is very, very unaware. And even if they're aware, I think the gravity of the issue, how big it could become, how serious it could become, is still missing. And more the people, professionals, industry, I think everybody has to, to speak about this. I remember when I had joined Essilor, this is the time we actually started speaking about presbyopia and progressive lenses. So I think that same kind of effort and initiative has to be taken by everybody for this whole category of myopia, and the fact that you need to manage myopia if you need to have any kind of future for your child.
Thank you so much, everybody, to give your personal take on the current hot topic of myopia. On this note, we are now at this juncture, I would say that the awareness amongst practitioners as well as the public is very poor. We are still in the dark as far as myopia, its progression, as well as control is concerned. So on this note, do you think communication is a very important part as far as talking to parents or people with myopia are concerned about what is myopia, why is it progressing, and why is its progression a concern to everyone? Dr. Reggie, as an ophthalmologist, what do you think about it?
Yeah, that's a very serious problem. And the first question most parents ask, do my child really have to wear a glass? So wearing glasses itself is like a social stigma. And it's a question of denial. Many parents even refuse the fact that they really need it. And even if you prescribe, they tend to go back. So it's important to set up some time, because this is a lifetime problem with whoever is going to get those glasses and whoever has myopia. So I think you need to explain to them really that this is a problem. The child will not see. It's the child's competence. It's ability to face the world, and even in a competitive world, could be decreased, or the child could be deprived. And therefore, you have to make the parents understand. And one of the simplest ways that I tell a parent to see, even I wear glasses. So the minute you tell them that, they feel good. Okay, at least my doctor is wearing glasses, so there's a possibility. Yes, there's nothing wrong that they can wear glasses. You don't even have to tell them that you're wearing presbyopic glasses. But then you have to tell them that the next question is, can I stop it after 6 months? That's a typical question. Okay, or do they have to wear it for life? And you can actually see their faces just drop. Then you say, yes, possibly yes, and you need to check, and there's a possibility that it can go up. If it is me, I would actually wait for them to come back to actually drive in the complications and things like that. But I would take the second opportunity when they're used to the child wearing glasses, used to the fact that the child, without the glasses is not able to see as well. And at the second sitting, I would then tell them, see why it's important and what are the possibilities if it progresses. And more so when you see that it's progressed a little more, that's the best opportunity to tell you, yes, see, it's going up. You need to be careful, because if it goes beyond a point, and then you tell them what is high myopia, the risks of high myopia, which includes macular degeneration. You can even develop cataracts, you can have glaucoma. Those terms sound Latin and Greek to them, but you still tell them that there is a weakness of the eye which can progress. Then, you have to keep coming back. That itself is a nightmare to them. So you need to tell them that you need a regular follow-up once in 6 months or once a year. And if there's a progression, then you give them the options of what are the available ways by which you can possibly, even these are not foolproof. You have to say that these are options by which you can, to some degree, decrease the progression. So, it actually means time, which I think was lacking till a few years back. And people have started spending more time with myopic children and explaining to the parents what is what.
Thank you so much, Dr. Reggie. Dr. Pawan, what's your take on this?
Dr. Reggie did not leave anything for me to cover, but I think picking up on the time, if you are seeing 70, 80 patients in your clinic, or a busy clinic, you cannot do justice for a child with myopia. I think parent counseling is one of the key parameters that we have to keep in mind in the myopia management. I think that's important. Just because there is myopia, first of all, you don't want to give these myopia control strategies. So unless you understand, explain them, even if you have to. So I take this approach in two ways. Child with myopia, even if it is stable, I think it's important for us to educate them about, hey, today it is stable, but we do not know how it's going to change in a year time. If it is an obvious case of progression, then comes in the the existing or the available myopia control strategy. So yeah, I think the important message that I want to pass on is the time. See less patients if possible, if you are looking at the individuals with myopia. Otherwise, first of all, they don't understand, hey, this is a, chashma de diya, it's end of the story. But what we are now advocating is it's beyond providing single vision lens. We have to tell what is it, why you really have to go to this, what will happen if you're not going to, get this myopia control strategies. Time.
Thanks, Dr. Pawan. Lakshmi, you are a practitioner as well. Would you like to add in a couple of comments on this?
Yeah, I completely agree with what Dr. Reggie was saying. First is shock when you tell them, right? The acceptance that the kid has a refractive error. First thing is, if the parents are not myopic, it's even more of a shock, because like, we are not myopic, how come the kid is myopic? The next question is, can I give them carrots? Can I give them spinach? To get rid of the power. I'm sure Anuradha also must have faced these things when she goes to school, because that's their reaction. So to acceptance itself, as both Pawan and Dr. Reggie pointed out, takes time. So I would say, like, not even inside the clinic, especially for optometry practices, I'd like to say, if your staff are outside, because many a time there are prescriptions which come, which they dispense, correct, outside when you're in the clinic. And if it's a myopic kid, the staff also needs to be educated in terms of, what to talk, or ask them to wait for some time so that the optometrist can talk to them. Because even that traffic, I'm saying, outside the clinic, where they just come with some other prescription of a myopic prescription of a kid, where they just are placing an order for a spectacle, even those people need to be educated. So basically it is spending more time, and also giving parents time to understand what the issue is. I think, you can't just throw everything at first one go and then say, digest this. It is quite difficult. If you put yourself in the parents' shoes, it's quite difficult for them to take that, saying that, this is going to be lifelong, and it is not as simple as just wearing a spectacle and getting rid of it. So that understanding, I think, is the key. And I think that's where many of the corporates and institutions like us or other institutions basically join hands and increase the awareness as much as possible.
I just want to add one more point, Anika, if you permit.
Sure, please.
So Monica has highlighted that, look at the eye and the human in total. That's very important. I want to emphasize that, at the same, while we educate, there's no need to scare them off, but assure them that, hey, there is now solution that's available. I think once they get that assurance, and depending on not just the eye, but look at that person, look at the affordability, look at various aspects, provide them assurance, and think they will understand the problem.
Thank you so much, Dr. Reggie, Lakshmi, and Dr. Pawan. So for now, until now, the discussion has led to the conclusion that myopia pandemic is real. Myopia progresses, you cannot revert it, and myopia progression needs to be brought under control. So that is understood. But then there are also several options that are available towards control of myopia. There lies the confusion amongst practitioners. So somebody who is more into an optical setup may not be comfortable with offering a contact lens as a solution, an advanced contact lens design option, or anything like that. So I would like the panelists to pitch in and give your take on the several options that are available, and how does one decide upon which suits or which is the best option, or is it combination therapy that works the best? Because practitioners' level of awareness appears to be poor in general, and we all need to be on the same page as far as myopia and its control and its management is concerned. So we need to start at the same level. So to help them understand better, if Monica ma'am, if you could start up in telling us a brief on what are the options available, and maybe touch upon contact lens as an option for myopia control, it would be great. And then probably Dr. Reggie could take up the pharmacological intervention as far as myopia control is concerned. And then we move on to anybody else who wishes to pitch in.
See, I would rather add in continuity to the previous question also, the communication. My thought and message to all practitioners is whenever we start with any myopic child, I think it's the ownership is ours and we are accountable to start briefing every parent at least on the environmental adaptations. Why do we wait for progressions? And we know progressions are going to happen. So it doesn't take much time, but these small tips, which are really research proven, like reducing the near work, limiting the near work, I would say, I mean, whatever best beyond the study time. The second is the use of these digital screens and the child holding the books or the reading material too close. The third, very simple one, outdoor activities. And it impacts, that communication with the parent at that very moment helps. And when we come back, we can give them an idea that it's very likely your child with the growth can have a progression and you should be made aware of regular follow-ups. So my take as a practitioner, I would suggest that give them all the advantages of understanding this at the very first moment, because the public is also now knowing more about it and we have very educated parents. They themselves read and come back. They may come back to say that the practitioner is not so well educated because they did not talk to me, or maybe it's not for me, things like that. Now, if I talk about the categories are very simple. One is the pharmacological, and I know the ophthalmologist, Dr. Reji, is a better person to answer that. Yes, in the other category, we have the optical solutions. 5 years back, when I started myopia control, I only had the contact lens option and orthokeratology as a procedure where the child would sleep with the lens at night. And yes, we could control. 5 years follow-ups, very good promising results, but you have to be very restricted number of patients that you can fit. The kind of patient selection criteria are very rigid in terms of myopia and the parents' education, and cost is prohibited at times. Very recently, we've come across these optical solutions now in India, especially the spectacles. Personally, since the day I have started on with these myopia control spectacle lenses, I don't think any parent is not convinced. They are in any case wearing spectacles. Shifting them to special spectacle lenses, which are myopia control spectacle lenses, has been a very easy communication with these parents also. And it works. Research has given us that information and data that yes, these strategies work. Yes, there can be many more additions to it. So first, environmental control, mandatory, even if we do not find for any myopic child, even if we do not find progression happening, let's stop the child from getting into bad habits. And it does. I think we're hardly seeing any child which doesn't. The second is pharmacological and co-management with the ophthalmologist, because the results sometimes say if you have both the things together, sometimes it works better. Follow up these children. Optical solutions, very easy take and easy compliance in terms of spectacles. And last, orthokeratology, which promises to be one of the best.
Thanks, Monica, ma'am. Dr. Reji, your take on pharmacological interventions for myopia?
Yes, just like Dr. Monica just mentioned, there's a spectrum with which you can handle kids. To me, in practically looking at the number of patients who come in and different strata of people coming in, like Monica said, I would be the last person to try contact lenses because you're talking at an age where the children are not responsible. So, and we also know that complications with that are near permanent complications if they are significant, like infections and things like that. Now, when it comes to the three options that I would practically follow in clinical practice, one is, of course, even if you just look outside your own clinic, you'll find these progressive myopes, either they're fiddling with their mobiles or they're with some book reading those books. And they're basically indoor kids. So one is you have to tell them and tell every parent, outdoor, 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 do a lot more, exposed to sunlight, do outdoor things. That's one which I would do. Two, I would look at atropine. When it came to pharmacological thing, actually the percentage of atropine that we use today was not actually designed to treat this or to handle myopia. It was a study where they tried 3 different percentages, and 0.01 was just a control study. And there they realized that the lowest percentage was almost as good as the highest percentage, and therefore atropine 0.01% came into being. And it basically decreases the amplitude of accommodation. The child doesn't accommodate so much, and therefore prevents the progression. Very simple to use. When you especially use 0.01%, the quantum of allergies, the side effects, including the pupillary dilatation, etc., is very, very minimal. So it's a relatively safe drop to use, and you can use it long term. And the rebound phenomenon is also much less when you use atropine in a much lower percentage. So it's a very good option for the fact that it has proved to be one of the best over a 3-year study, 2-year study. It has proved data. And now, of course, with the new lenses, which has a double, the center focusing at the center, and then the rest of it creating an image in front of the lens. That again explains, it's a lot of neurophysiological explanations to it. It prevents the eyeball from growing. So whichever way you look at it, here you're preventing a progression. And the risk that you're having is very little in both atropine and with these newer technology glasses. So that would be my take primarily. And two, when I've already given the new glasses to patients, and patients are quite happy. Yes, when you tell them it has many, many eyelets around and things like that, they look through the side and tell you, yes, it looks a little like that. But otherwise, when they put it on straight away, they are quite comfortable. Yes, there is a cost to it. And if you look at the cost between atropine and the other, there is a cost difference, but I would go by these 3 choices. And undoubtedly, the glasses have made a big impact, because there's no drops, there's no side effects, and nothing wrong in trying something which is not an intervention per se.
Thank you so much, Dr. Reggie and Monica, for elaborating on the different myopia control options that are available. Having said that, we cannot deny the importance of binocular vision evaluation. So Dr. Pavan, if you could stress on how important is binocular vision evaluation as far as myopia and its control is concerned?
I would want to start by saying that the myopia examination, specialty examination, and the management should be more personalized. So you go to only personalized only when you have a lot of risk factors that are assessed. And the various studies indicate that much like time outdoor, more near work, the binocular vision status, accommodative status are very precious for you to really, understand what's the status of that the eye is. In our clinic, we map the Fourier status. Is it ESO or EXO? What type of ESO for near and distance? We look at the accommodative error. Is there a lag or lead? What amount is that? For example, if you have to go with bifocal as a spectacle, studies indicate that it works great when there is ESO. And if there is EXO, then it sort of triggers for the ocular muscle imbalance, and you are only aggravating the situation. So I think the assessment needs to be made on multiple fronts. Binocular vision is one of the important areas that we need to really look at to end up by providing the personalized treatment. I think we need to look at multiple risk factors wherever possible. Saying that, I'm not saying that, hey, if you want to really see myopia, or a child with myopia, you need to have A, B, C, D, E. I'm not saying that. Even within the scope that you have, I think as an optometrist, you will be having a retinoscope, you will be having an autorefractor, you will be assessing visual acuity, few things you can do, cover test. I think whatever is within your vicinity, is within your scope, I think we should tap on those aspects, but not just look at the central diffraction and then provide these aspects or the myopia control solutions left, right, etc.
Thanks, Dr. Pavan. And Dr. Anuradha, you are the head of the school vision screening program. So I'm sure you have a great protocol in place where binocular vision evaluation is a very important aspect. So what's your take on the importance of binocular vision evaluation as far as vision screening programs is concerned?
Yeah, thank you, Anita. We have based on a study called as band study that was done at Shankar Netralia, we had formulated the minimum test battery that can be done for all the school children, because everybody sees binocular vision as a very complex process and not everything could be done when you do screening for school children. So that's when this study wanted to at least freeze the minimum battery of tests, which was like testing, as Pawan was telling. It was basically to test the status of the near phoria, and then it also tests the accommodative facility and measures also the convergence parameters, the near point of convergence basically. So these are the three tests that we use for screen while we screen for the school children. And again, we see that the prevalence of non-strabismic binocular vision anomalies is somewhere around 30% in rural and urban areas. And of course, combining it with myopia, Pawan had beautifully pointed out the connection between myopia and these binocular vision screening. And many things remain unexplored in the area of myopia and binocular vision. We don't know what all will be significantly contributing. As of now, we are discussing about lag, near phoria, those things. But if we have a baseline documentation of at least these minimum parameters on binocular vision, maybe in the future, many more works could be added along with the other detailed components of myopia evaluation in the hospital. So that's what I would like to recommend.
Thank you so much, Dr. Pawan and Dr. Anuradha. So I'm going to throw open a question for all of the panelists at this moment before we take up questions from the Facebook Live audience. Like having said all of this, do you think a very structured program or a focus on the basics of myopia control and management is in need of the hour?
So I'd like to step in there. So I think one of the things that I have learned in the last almost 1.5 years of meeting all kinds of professionals and parents is that everybody has a different way to talk to the parents. Now, considering the fact, I think some of you have said that it is such an emotional issue for the parents, it would be so great if there was a process that is followed while talking to the parents. So I know that that ophthalmologists have probably their own process. I'm sure the optoms have their own process. But I think if it's something that is aligned, where you have a step 1, step 2, step 3 like that, and then everybody speaks the same language, you then are able to reassure the parent a lot more. He or she is already agitated. We're throwing a lot of numbers at them. We're throwing a lot of possibility of the child's future being different from what they thought it was going to be. I think putting a process in place definitely is reassuring. I know as a parent, I would be very, very reassured.
So I would like to add, yes, continue to what Radhika says. So there is certainly a varied kind of information. People need to be educated. And once you're properly aware, educated, and I think none of us, especially the practitioners who graduated out a few years back, have really heard about anything about myopia control. So it's education at any age who's in the profession. So to upgrade, it's not like listening to 1 or 2 things here. It has to be a structured course or a module which should be taught to everybody so that they can handle, which includes, yes, as Radhika says, the communication part and the technical part both. So personally, my stake, the awareness is one step, but the next step is completely educating every professional. And if he's properly educated, I'm sure the message will be rightly communicated to the parents, and the best thing would happen to the patient.
So,
I feel, can I?
Yeah, please.
So, listening to all the aspects, all these are like, I feel it is intertwined, this awareness part, communication, and then, the CE sessions that would be useful to the practitioners, all these are intertwined. Nothing can go alone. And I also feel like one time of doing any of these activities is not going to be adequate. It has to be repeated. Though we think among the professional circles that, okay, I often hear only myopia, I don't hear anything else, only myopia. myopia. But when you see outside, no, there is not much of information actually to the parents or to the teachers or to the children, not much of information. You won't believe, recently we did a quality of life study at ISN, and then we found out even now today, this was in an urban metro like Chennai, people are still not aware. No, they have a lot of reasons, like I put an eyeliner, I put a cream to rub that, and then I went for examination next day, I had myopia. So things like this still we are able to hear. No, that means how much ever we do, it is not going to be enough. So that is, we have to keep on doing it, sustain it, both for the beneficiaries and for the practitioners. So that is very, very important. The second thing is the time part. Everybody said no, we should remember there are going to be, it's going to be a difficult situation in the future. That's what I'm foreseeing. Previously we were only talking about the private school children, no, where the prevalence is very, very high. Now looking at the figures, I'm also seeing an uneducated, or I shouldn't say less educated parents who are also going to have their children with high myopia, increasing numbers. So while the educated parents themselves do not know the options, do not know what is going to happen, and we are going to have a new set of parents who are less educated. So how are we even going to address this? Are our practitioners equipped to handle the numbers and also the diversity of these audiences? That is another question that we need to look at. The other aspect is, I feel myopia is management as one component where everything from preventive, promotive, cure, and rehabilitative, all measures are required in terms of healthcare management. And as people, all of you beautifully pointed out, the steps, clear steps as to 1, 2, 3, this should be the solution. In all these aspects, such steps should be brought out, and that should be conveyed to the practitioners as education sessions periodically. A one-time session, even if I say I am a certified myopia practitioner, this upgradation is constantly going to be required with new and new evidences that are going to be in place. So all these aspects, the holistic aspects like preventive, promotive, curative, all these aspects, awareness, integration of everybody's role, and then sustained periodical sessions, these are all going to be key in ensuring upgradation of any practitioner or even starting of this. Like even now I saw a patient who said, I thought contact lenses are just for making my eye color look different. Still there are people existing like that. They don't even know that contact lenses can be used for instead of spectacles. Then we are talking about hi-fi terminologies of myopia management. Not many are aware. Still we are only targeting a minuscule percentage of the population. So much more to do, and integrating all this is very, very essential.
Yes, Lakshmi.
Can I say something?
Please.
Pavan is laughing.
I was to say you will be charged per word.
No, I'm just saying with some past experience, Anuradha and Monica are quite familiar with the experience vision study that we did, where we went to all the schools, government schools, and tried to give an eye awareness lecture and also gave them posters. See, with India, it's so diverse that even if we develop, I just want to make a point that if you're developing communication material or IEC material, we need to make sure that it's translated in many languages. Otherwise, it is not going to reach as many people as we think. And I think in that project, we really saw the huge difference in terms of impact of conveying the message when it's in their own language. It goes through so much more better, especially with what Anu is saying. It's not just urban alone, it's also the rural that's getting affected. That is one. And I think second, I really feel the need of developing some kind of a best practice standard protocol for myopia management. Because that, I think once that is in place, then educating the practitioners with that protocol in place becomes much, much more easier. And they also can follow some set standard, whereas now they kind of are groping with so many educational sessions happening as to what is the protocol to be followed, like whether binocular vision is to be done, not done, and if we find which kind of control measure do you use? Do you use the hyperopic blur one, or do you use the accommodative one? So I think in that way, if we can develop something that I think is definitely the need of the hour. And to the third one, I just wanted to say was like how Radhika was saying earlier, it used to be presbyopia. And at that time, to be very honest, because we used to keep saying, oh my God, enough of this presbyopia education, because that's how it was at that time. But look now, everybody who walks in knows what a progressive lens is. Most of them, even be it in rural areas, they at least, they don't call it progressive. They will say the spectacle without the line. I want the spectacle without that line. So they know that something is there, right? Something is available. I think if we are going in terms of educating both the public and the practitioners, then if we go on a war footing like how we did in those days for presbyopia and parallel lenses, I think that would really make a difference.
Thanks, Lakshmi. You very beautifully summed it up. It all boils down to communication and educating both the practitioners as well as the public in this regard. So I would like to ask Dr. Pavan regarding the role of government towards myopia control, the policies surrounding it. I know you do work a lot in this area. So if you could answer this.
I think the government has a big role to play here. Talking about countries like Singapore or Taiwan, they have, the government has come into the picture. They made 1 hour mandatory in majority of the schools as an outdoor environment, and they're now seeing that the incidence of myopia is coming down, or the progression rates are a bit less compared to the ones who do not have that extra 1 hour recess time. In India, like everybody said, there's big diversity in terms of the socioeconomic status or the developments that we are having, the type of schools that we have, and reaching out to 1 billion plus population is not an easy task unless government comes into the picture and as an advocacy or as a policy. If tomorrow government says, I think I want to take you back to that paper where we said, hey, today the prevalence of myopia is about 20-25%. If you leave it as is, it's going to go in a linear manner to 45-48% by 2050. And we said, let's say if government jumps in today and say everybody, be in outdoor environment for 1 hour, everybody, not us, children, school going children, 1 hour if they get, then the numbers will drop down. Instead of 45%, maybe you will see 30% or 28%. So you are really, the flattening the curve by significant amount. So I think it's important that people or all the stakeholders come together to work with the government. I mean, government is people, people is government. So somehow we need to look at what strategy to be employed to ensure we, reach out to the people. On that note, I want to also highlight that, yes, there's a lot of noise, but what we know so far is very little, and myopia is almost like all the oceans put together, and we are only, touching up few drops and not really even a liter of water. So there's a lot to be done. All of you have spoken about the education, patient care, but I want to highlight that this also means the scope for research. And India stands very unique because the prevalence is not high, but there's still, it's increasing. So this is time for us to really spend more time on research as well to ensure you prevent it now or to understand the causation.
Thank you so much, Dr. Pavan. In fact, I would like to even mention that, many governments of the Southeast Asian countries are taking up major roles in especially promoting outdoor activities and making it mandatory for school children to go out and play. Like they have very many posters, at least the Singapore government, the Taiwan, Hong Kong, China, they've taken a lead in this. The government has taken, great measures in ensuring that every school kid has playtime, sufficient playtime. Unlike if you compare with the curriculum in India, it is so focused on education that, even my boys used to complain that today we had our PT period, but our maths teacher or science teacher took up that class. So those two classes were taken up by a teacher. So this is the state of affairs. Even when there is allocated, outdoor play time for children, it is taken up because we are heavily focusing on curriculum and studies all the time. So this is a big problem, I would say. So
the other problem is there are few schools without a playground.
Oh yeah.
So now
That's
where do they
another
go?
story.
Lots of them.
Lots
of them.
Plenty like that, I would say. So we would now move on to our live audience. I know lots of questions piled up in the Facebook chat. Lakshmi, if you could just help me. But there are a couple of questions pertaining to a particular method of myopia control, pertaining to perhaps contact lenses or spectacle management. So I would request all of you to just hold on until the end of the session, because I have something important to share with each one of you. So if there are any common questions which we can open up for our panelists, it would be great. Lakshmi, do we have any such questions?
Yeah, before that, I just would like to make a comment on what you said about policy. So the Myopia Task Force did develop what's called as a Myopia White Paper, and we have submitted that to the government as well. And we have not seen any action on that front. But I think we would, we would continue to push. And I think, issues like these, if all the stakeholders, as Pawan said, everybody gets together and then goes and does a representation, maybe, that would hit harder than just us going and, looking at, asking them about or informing them about the issues with myopia. So
in fact, I would like to just add, remind you that we went and met actually the Ministry of Education and also the Sports Ministry. So that these could be combined, because not one department is involved. If everybody could come together, I think the OCA white paper beautifully covers all important aspects. Though it is sometimes it looks ambitious, but that's the way forward we all believed in. And the annual eye examination for all school children, that we emphasized in the OCA white paper on myopia. And then of course the classroom size, the playground size, everything, according to the standards. If you could come up with policy decisions on such things and then submit it to the government, then it will be a dream come true, definitely.
I'll just tell you, Anuradha, so the sports people have got back to us. So the reason I'm talking about the sports ministry is because we got a window to kind of screen athletes, and we use that window to, talk to them about myopia and all of that. So now they have got back and said that, can you look at all athletes, different kind of sports, because some are exposed to sun, some are not exposed to sun, and look at, refractive error, and speak to them about, whatever, either you want to give an intervention or speak to them about outdoor play and all of that. So that is something positive. So let's see how far that goes. Monica wants to say something.
Yeah, I wanted to add that as far as Delhi NCR schools are concerned, the policy is already now executed. All schools have been given directive that there has to be a battery of those dental and other physical examination, and even this eye examination, which is mandatory for every annual eye examination. And schools which are funded are given some support on that also. So it started happening here as a policy, which was there, but they're reinforcing it. And the second thing I would like to say, one of the observations which has been found when we were talking to certain school principals while we were inaugurating some myopia control centers, and even general public that is coming across, patients and parents. You see, the world is digitalizing. The children are digitalized now, and you can't stop them. Even the schools are now going into paper-free work, everything. Thanks to COVID, they're learning those easy methods. It's not easy convincing them that that near activities and things. Parents are really frustrated. Children are not listening at that front. So it's only the message, yes, which comes next is outdoor activity to be enhanced. Pawan rightly said, many schools even do not have good playgrounds. The curriculums, Anita said, is very right. They are so rigid on it. In fact, this is one of the principals of a very prime school here telling us we hardly finish the curriculum, that we just cannot afford to add in an extra hour or anything into the school for these activities. So new strategies have to be thought considering the urban, especially the urban kind of environment children are living in. We are knowing the world can take it easy. The curriculums in developed countries in US, Australia, and UK are different than what we are going through in our education things. So I think a more practical solution to the parents will have to be communicated. And even when we go, we cannot just threat them without giving them a practical solution. More deliberations need to be done on how it can be taken up in today's environment that we are.
Thank you, Monica. Anita, I'll just read a question. I think it's more to Pawan and Anuradha. What's the take on the role of accommodation lag in myopia progression? Now, we are focusing more on hyperopic defocus in the retinal periphery.
Good question. Few studies indicate that accommodative lag does not have a role in myopia progression, based on a couple of papers that has come up. But near work is very important, or considered as important risk factor for myopia. When we talk about near work, obviously there's more accommodation. I usually talk about two different theories. Number one is accommodative lag theory that says there's more lag, more hyperopic defocus, and that could act like a signal for you to really increase in the size of the eyeball. But let's forget the lag now and then look at the accommodative stress, or the the mechanical tension the eyeball has to undergo for it to really focus onto the near target. That's what we call it as mechanical tension theory. So if you're accommodating, I think there's a lot of stress, and that could really send signals for the eyeball to grow. So accommodation per se is very important. As I said, it's an ocean by itself, the myopia field. There are always like conflicting results that come out from the research setting. But if you ignore the accommodative lag element, the mechanical stress is always there. So I want to keep it accommodation in general and its importance in the myopia progression instead of just sticking to the accommodative lag.
Anu, you want to add anything to that?
No, I think he covered the hyperopic defocus part. Maybe all the spectacle-based interventions are also thinking and working with respect to the hyperopic defocus aspect. So I think it's all the more important to be thinking about hyperopic defocus per se. So that's the strategy that we should be looking at. Yeah, I think Pawan had covered that.
Radhika, there's one question. It says that today we are telling myopia to optometrists regarding dispensing. Do you see that in the coming days it will be available as over-the-counter like progressive lenses?
I think progressive lenses are also not over-the-counter, so you can't go to a medical shop and just buy it. I think that there is some amount of counseling that's required for any product that's probably meant for a long-term good of any kind of a patient. So no, I don't think these will be over the counter. I think it will require the intervention of an optometrist. It will probably require the intervention of an ophthalmologist, also the eye care practitioner. See, this is an entire ecosystem that will have to kind of lead patients to products that are good for them. And I know all of you have talked about, contact lenses, spectacle lenses. We have just launched a product called Stellis. But I think every solution has to be evaluated as to what is best for the end consumer. So that's where everybody has to work together to say, okay, this is the patient, this is his lifestyle, this is exactly his problem, and therefore this is what he needs. So if you need to reach that kind of a decision, I don't think that can be done over the counter. Not yet.
And Lakshmi, just a point here. I don't think it's like buying a ready-made glasses for progressive and buying a progressive, for presbyopia and buying a progressive glass. I think this needs education, and
Yes.
these glasses are very specific for progressive myopia. It's not a glass for myopia.
Correct.
So we need to differentiate the two itself when we are talking about any of these treatments. There's a difference between just absolutely stable myopia and progressive myopia.
Yes.
And very many of this myopia management devices or whatever you're using is for progressive myopia.
Rightly said.
Yeah. There's one more question on orthokeratology. I'll just comment and then I'll ask Monica to add on. Basically, they are asking the age. Well, I would say like we have in our practice successfully fitted kids from 6 to 7 years as well. I know like Dr. Reggie was saying, they're very small kids, but to our surprise, they actually maintain the contact lenses better than some of the teenagers that you get for regular soft lenses. I think the motivation for them is because they're getting rid of their glasses and seeing well as soon, once they take it off in the morning. Of course, the parents oversee, but over a period of time, we've seen that they just do it on their own. They don't need any help and they maintain the lenses well. The frequency of follow-up is also a question that's been asked. I would say one day is the first day is very, very important. You have to open your clinic quite early, see them close to after they wake up and remove their lenses so that you can have a good topography map and then follow them up after that. Risk of keratitis is there's so many papers on orthokeratology and keratitis where they're saying it's close to just daily disposable contact lenses. Monica, you want to add anything to that?
I endorse your statements, and my youngest one is 9-year-old. Of course, 6, 7 years, of course, can also be done. And children within a week or maximum 1 month, we of course educate the mother first, but they have become very independent. So far, no complications, last 5 years of experience that I have. But the beauty of this is they don't want to get off the orthokeratology ever now, because they're like emetropes without glasses, without contact lenses. And it's been a beautiful strategy. Amazing results. A child who was progressing by 1 diopter is just 0.25 diopters in last 5 years, from 12 years to she's now almost 17, 18 years of age. The 9-year-old also 0.5 in 2 years. Maintenance is very good. Parents are happy and the compliance is excellent. Children don't even want a day to be skipped off because they see so clear with it. Personally, yes, but the right selection, right follow-up, picking the right one, just not haphazardly doing orthokeratology. If it is done in a right way, it's a beautiful strategy. And sometimes, yes, we combine it with the other therapies too.
Point here, India has only one Lakshmi and one Monica.
No.
Many more to follow. I think the purpose OCI is driving is this only, that
we need
educate yourself, and there will be many more.
But I think there's a disadvantage as well. Cost is a big disadvantage. And as Monica said, patient selection is the key. You can't give it, to many people. And I think that's where the spectacle option really is, is something like
it's a boon now. In fact, last 5 years since we were doing orthokeratology, whenever we said, at one stage we said you need to control, and the other stage I did not have. Perhaps I've been speaking to Essilor and the other optical industries. They were globally available. When are we getting them? I was the happiest person because we have now a range of options for our patients to offer.
No, Lakshmi, what I wanted to make a point here was that I'd like to know among eye care practitioners across this country, how many people are actually using slit lamps, how many people are actually evaluating patients with slit lamps, etc. Now, when you're talking about contact lenses, if you don't do that, I think it's an absolute failure.
Totally.
Now, if you look at that perspective, I would think go look at something which is safer rather than try something which is dangerous. And if you look at that, undoubtedly either atropine drops or the new modality of glasses score a total plus. Because that's what I meant, that how many Monikas and how many this ones are in the country. Very, very few. If you take the whole of Bangalore and look at eye care practitioners, not even 1% can even know what a slit lamp is. So we're talking about a totally different spectrum. And yes, in the best of hands, it works, but not in everybody's hands.
And topographer, of course, you forgot. Not everybody would have topographer. And orthokeratology cannot be done without those follow-ups too.
And just something I just experienced with spectacle dispensing with myopia, like what Dr. Reggie was saying, like also Radhika says, keep expectations low. When you keep the expectations low, to my surprise, like a couple of them who we've given spectacle corrections where we said, there are these things you might see a little bit odd, but to our surprise, they're all comfortable. They don't see the distortion at all. The patients absolutely are not, unless you kind of show the lenses to them against a white light, then they see it out of curiosity, the kids, but otherwise they are absolutely no complaints of any distortion or something that's, vague or things like that. So they really, I think as kids, they adapt very fast, either that or, and when you've already told them that they might see something like that, even despite that, they basically just come back and say, no, it's like my earlier glasses. I don't see any difference. So that's something really.
My patient had 2 days adaptation. I probably feel it's more of the centering and the frame selection and the fitting, the optician's role in it. You may have done it personally at your own clinic, but one of the patients, yes, a 2-day adaptation was observed. And simply it needs the best of the dispensing knowledge also. So it's not over the counter again, adding on to one of the questions. You need a good professional, even in selection of the frame and fitting these spectacle lenses.
Okay, over to you, Anita. I think everybody is waiting for something.
Thank you so much, everyone. I feel by far this was one of the most stimulating panel discussions that we've had in a long time to come. And we have the best of the heads or the so-called experts in the field of myopia today on this panel. So I thank each one of you personally for having taken your precious time out and sharing your perspective on myopia. So for all the audience who have joined us live on Facebook, thank you so much for taking your time out and listening to the esteemed panelists today. And I'm sure you're awaiting for that major announcement. So as the discussion was happening today, let's all come to a conclusion that the awareness level needs to be propped up as far as practitioners are concerned, as well as the public is concerned. So we as practitioners need to follow some best practice standards or protocols as far as myopia is concerned. So all of us are on the same page. Communication is a very important or a key aspect in myopia and its management is concerned. So having said this, so we at OCI thought it was apt to launch a course so that the basics of myopia, its progression and management of myopia is well understood, because we have had, bits and pieces of information here and there, webinars happening over the past 2 years, thanks to the pandemic, that we have been sitting in the comforts of our house and listening to experts across the globe. So we thought this was the right time that we launch a very basic course on myopia control and management. So I'd like to share this. So for all of you who have tuned in today, so thank you for joining us. And please watch out for announcements on the course on myopia control and its management on all the OCI's social media platforms. So we will be making the announcements soon. So we request all of you to stay connected. We are on Facebook, Instagram, LinkedIn, Twitter, YouTube, as well as Telegram. So we will keep you all posted about the launch dates of this course. It is again going to be on the online platform. So please stay tuned, and thank you very much again, all of you, for having joined us today. So Lakshmi, any concluding remarks?
Thanks to all the panelists, on an afternoon to, we've crossed 1 hour also. So, and before the session, everybody logs in as well. So it's almost like 1.5 hours. Radhika, I think you've been sitting at the airport lounge for quite a while. So thanks for that. And thanks everybody for all your time. Monica taking time off from your clinic, Dr. Reggie as well. And Pawan, he's very, very difficult to get. Or he, I think, stays away from me because saying this lady is a headache. I don't know. He's very difficult to catch hold of. So thank you for having spent all the time. And Anu as well, away from all your students and classes. So everybody, thanks a lot. And the face behind this entire session is, of course, Anita and Urmi. I think she's been having some network issues. So both of them from OCI. So thanks a lot to you as well. So I just, they make my job very easy. They make everything ready. They just say, you just come, say a few words, that is enough. So I think I'm the most blessed out here out of everybody. So thanks a lot, everybody.
Thank you.
Thank you.
Thank you so much.
Thank you.
Congratulations to whole team and OCI. We look forward to it.
Thank you.
Thank you all.
Thank you so much.
Thank you.